So at this point, I'd like to introduce Dr. Sharon Weissman. Sharon went to medical school at Columbia, did her residency at Beth Israel, followed by a fellowship in infectious disease at Beth Israel. She's currently professor of clinical internal medicine at the University of South Carolina at Columbia, as well as the program director of the ID Fellowship.
Good morning, everybody. I know we went over a little bit, but I'll try to catch you up. So, glad to be here on this beautiful island. I'm going to spend the next 45 minutes or so talking about sort of hot topics in infectious disease as they relate to women. And of course, I will get to Zika virus, since that seems to be the hottest thing this year. This is just a brief outline of topics I'm going to cover, from vaccination to antimicrobial resistance, a little bit on HIV, and I'll end with Zika virus. So I'm getting right into it, starting with the flu vaccine. So as most of you probably know, since 2004, the flu vaccine has been recommended by the ACIP as well as ACOG for women who are or will be pregnant during the flu season. And this is regardless of what trimester they're in. So the question is, how well are we doing with these recommendations? Are we following along with them? And this was actually a nice study. It was an inter-based study of over 1,700 women who were pregnant during the 2014-15 season. And what they found was that only about 50% of them reported having received a flu vaccine, and maybe a little less than 2/3 were even offered that vaccine. And as you can see, about 15% received recommendations but weren't offered the vaccine, and another 20% had nothing. So this is important because it was showed that they showed that vaccine coverage rates really correlated with whether or not we recommended or offered them. So just something to remember, that if it's flu season, pregnant women can get vaccinated, and they should. It's recommended. If you're worried about the effects of the vaccine on the baby, this was actually a really nice study over many years, in which they included over 240 mother-infant pairs, and they looked at the impact of flu vaccine during pregnancy on the babies. And what they found was that the mothers who were vaccinated, first of all, only 10% of the mothers received a vaccine during their pregnancy. And this was from 2005 on, so after the routine recommendations for flu vaccine was begun. What they found was, though, that the infants of the mothers who received the vaccine were 64% less likely to have an influenza-like illness, 86% less likely to be hospitalized for influenza-like illness, and there's a 67% reduction in proven laboratory-confirmed influenza in the infants. So not only is the vaccine recommended, but it actually did protect the baby if you gave it to the mother during pregnancy. So the next question is, well, what about the impact on birth outcomes? Does giving this flu vaccine to the mothers during pregnancy affect the birth outcomes? Well, here are two studies that showed no, it did not. As a matter of fact, if anything, women who received the vaccine during pregnancy had better birth outcomes. The first being a study from Laos of over 5,000 women, of which about 43% of them received the flu vaccine. And they found that the mothers who received the flu vaccine were about 1/3 less likely to have preterm delivery, and that there was really no effect overall on birth weight or gestational size of the baby. So there was no bad outcomes on the babies who received, if their mothers received the vaccine. Another study in Australia, which included over 58,000 births, again, you can see very few women received the vaccine, less than 10%. But of those who did receive the vaccine, there was a 51% lower rate of stillbirths. And that this actually decline in stillbirths was associated with the flu season. So it seemed like there was a temporal protective effect. So if you're not doing it, make sure you do recommend flu vaccine to your pregnant women, and offer it, not just recommend it, because it helps them. So switching gears a little bit to the pertussis vaccine, I think many of you know that there's been a recent resurgence of pertussis, our whooping cough, and this particularly affects our children and infants. They're most vulnerable to bad outcomes from pertussis. Adults, we just get bad coughs, that don't go away, but we spread it to the young kids and they have bad outcomes. So ACIP and the CDC do recommend that all pregnant women receive Tdap, which that's the tetanus acellular pertussis vaccine, at 27 to 36 weeks of gestation, and at each pregnancy. So even if they're getting pregnant each year, they should keep receiving this. And one of the reasons they recommend that you should be revaccinated at each pregnancy is there is a decline in protective immunity within 9 to 15 months of receiving the vaccine. Now, one group actually looked at vaccinating women earlier in pregnancy, in the second trimester, because if we wait to the third trimester, we miss women because there's just a lot to be done and a narrow window of opportunity to give that vaccine. And this study did show that if you widen the window for vaccination, not only did you decrease your missed opportunities for vaccine, but that the vaccine was very protective even early when given earlier on in pregnancy with no bad birth outcomes. So go ahead and do it. You could even consider doing it earlier in pregnancy if that's when the woman is there. So switching to the last of the vaccines I want to talk about is the HPV vaccine. So in December 2014, the third HPV vaccine was licensed in the United States. That's the Gardasil 9, which includes 9 valent types of HPV virus that are listed there. As you know, before that we had the Gardasil 4, which included the 4 HPV types there, 16 and 18, which are the most common causes of HPV-related cancers, and 6 and 11. Which most common types of HPV virus causing warts. And then before that, we had the Cervixix, which includes 2 HPV valents, just the 16 and 18. The HPV vaccine is recommended for girls and boys age 11 to 12 with a catch-up up to age 26 years of age. And it's a 3-dose vaccine. All of these are 3-dose vaccine at 1, 2, and 6 months. But as we all know, it's hard to get teenagers in at 1, 2, and 6 months, so you can have some flexibility in how you actually administer that. So the question, just a little bit about the Gardasil 9. I mentioned it includes 9 valents, so the 5 new ones are listed there in red, 31, 33, 45, 52, and 58. The HPV 16 and 18, which are in the older HPV vaccines, account for about 66% of HPV-associated cancers in women and men. The additional 5 strains in the Gardasil 9 account for about 14% of HPV-associated cancers in the women and about 4% in men. So the question that comes up in my mind, I have a 16-year-old. She was vaccinated 5 years ago with the Gardasil 4. So should I go back and now give her the Gardasil 9? Should I give her that extra 14% protection? So people have tried to look at that. The answer right now is there's really no recommendations for revaccination with the Gardasil 9. First of all, the benefit would be mostly for the women because remember those additional 5 valents of HPV in the Gardasil 9 only count for about 4% of HPV-related cancers in men, where it's 14% in women. The good news is there's no major safety concern in women who have received the Gardasil 9 after the Gardasil 4. There was a slightly higher rate of injection site reactions, but no major reactions. So it's safe. You can do it. The bad news, though, is if you've already received the Gardasil 4, that there's some interference with that prior vaccination that leads to a lower response to the 5 additional types in the Gardasil 9 if you revaccinate. So you could do it, but it may not be as efficacious as if you were to do it initially with the Gardasil 9. And then in a large sort of cost-effective modeling study, they looked at the QALA, which is adjusted quality life years, and they found that the QALA for vaccinating with Gardasil 9 after someone's had the Gardasil 4 was greater than 100,000. And that's sort of the accepted cutoff for when it's no longer considered cost effective. So it's at this point not considered cost effective to go ahead and revaccinate those girls or women who received the Gardasil 4 with the Gardasil 9. But it is cost effective to start switching your routine practice from using Gardasil 4 to Gardasil 9. So we should all at least start doing that.
Just a quick question. We have a lot of Gardasil 4 left.
Yes.
And now we have some Gardasil 9.
Can you go?
Monetarily, ethically, we can't send it back. It's very expensive.
Yeah.
What do you do with that?
That's a good question. And you can actually switch. If you started with the 4, then you can switch to the 9. That's safe. You might not get, again, as good a response.
Do we use the rest of those 4 then?
If it were my daughter, I would insist upon the 9. So that's a hard one. I would want the best protection. Maybe use the 4 for the boys, since the 9 doesn't have a lot of additional benefit, and and then start using the 9 on the girls, and then switch everyone over to the 9.
That is a common strategy. That's what my practice is doing, using the 4 for the males.
Yeah.
Okay. We were thinking about doing making sure all the males get at least one 9, but
yeah.
Or 2 of the 9s, 1 of the 4s, but maybe.
I'm just glad to hear that you're really thinking about it, because there's a lot of practices where people are not doing it, and the pediatric practices particularly where.
Yeah, I'm a pediatrician, and there's just a huge pushback.
Yeah,
especially with the boys. Really hard.
One of my colleagues, also an infectious disease doctor, when his daughter turned 12, went to the pediatrician, and the pediatrician said, "Oh, she doesn't need that," to him. And I was like, and he just looked at her like, "I'm an infectious disease doctor. What do you mean?" So I'm glad to hear that. So switching gears now, just a little bit on antimicrobial resistance. I was glad to hear in the last talk that you did not recommend clindamycin suppressive therapy, because we know what that does to the microbiome. Antibiotics are bad if you talk to an infectious disease person, because they lead to resistance. And this spring in the news, there was a lot of hoopla about the dreaded superbug that was found in a woman in the United States. You can see there was a CNN report. The Washington Post has quite sensational headlines. It turns out what this was, it was an E. coli that carried a plasmid for the MCR1 gene in a urine sample of a woman, 49-year-old woman from Pennsylvania. This MCR gene confers resistance to the antibiotic colistin. And if you haven't heard of colistin, that's not unexpected, because that's really an antibiotic of last resort. It's what we use when someone's resistant to all other antibiotics for those super bugs. So if developing resistance to that is very concerning, and the fact that it was on a plasmid, which means it can be transferred from bacteria to bacteria easily, is also concerning. In this particular case, although she had this resistant gene, her bacteria was actually sensitive to a lot of our early first-line agents. So in her case, it was easy to treat and get rid of, but it was concerning for what could be for the future of antibiotic therapy across the board. So this actually brings me to what I thought was an interesting follow-up study of asymptomatic bacteria. There was a study that was conducted many years ago in which women with asymptomatic bacteria were randomized to receive antibiotics or not receive antibiotics. And in that study, what they found was that the women who received antibiotics were actually more likely to go on to develop a symptomatic urinary tract infection. So this was sort of one of the landmark studies that made us realize that treating asymptomatic bacteria was not beneficial, it was actually harmful, with the exception of pregnant women, as I'm sure you're aware. This is actually a follow-up of that study where they continued to follow those women. They had 550 women who were followed. Half received antibiotics, the other half didn't. And what they found was that when they isolated bacteria from the women who received the antibiotics, they were significantly more likely to have resistant bacteria. So needless use of antibiotics leads to a resistant bacteria. And that difference actually in susceptibility persisted for 2 years after they received the antibiotics. So you perturb that microbiome, it lasts for a long time. So just one more reason to really not treat bacteria in the urine unless there's symptoms or, of course, it's a pregnant woman. So that's all for resistance for now. Now I'm going to go on to a little bit about HIV in women. So the good news is we've really made headway in perinatal HIV transmission. And actually, if women start their antiretroviral therapy, HIV-positive women start their antiretroviral therapy before conception, and they've maintained an undetectable viral load. In this very large study from France that over an 11-year period, they found that there was no cases of HIV transmission to those infants. Now, it's a lot. They have to start before they're pregnant, and they have to maintain an undetectable viral load. But these days, the recommendation is that everyone should start HIV therapy once they're diagnosed with HIV. So there's really no reason to start once they're diagnosed. Of course, a lot of times, the first time a woman is diagnosed is during pregnancy. But the good news is, if you can see down here, this just shows you the rates of mother-to-child transmission and when they started their HIV therapy. If they started before pregnancy, it was 0.2%. If they stayed undetectable, 0. If they started in the first trimester, 0.4%, and so forth. If they started later on, it was slightly higher at 2.2%. But that's, again, much, much lower than what we used to see when people were not receiving antiretroviral therapy during pregnancy, and rates of transmission were 25%. So really, we are coming worldwide to a closer to this 2% rate of mother-to-child HIV transmission, and that's great. I actually just came back from a work in Zambia, and Zambia has a HIV positivity rate of 14% in their adults. That means 1 in 8 adults is infected with HIV. But their mother-to-child transmission rate is less than 2%. So really, the medicines work, and that's great news. And even in hard-to-reach, resource-poor countries, we can achieve that. One of the problems, though, we have is keeping our women with HIV in care after they deliver. And this was actually a study from Philadelphia, but as I was driving down here, I saw another study out of New York City which showed similar results. And this looked at all pregnant women with HIV in Philadelphia and monitored their follow-up during pregnancy and postpartum. So the first 2 bars here are what was happening during pregnancy. And you saw that 92% of them were in care during pregnancy, and about half of them had their HIV suppressed. These bars show what happened postpartum. And what we see is by 3 months, only about a third of them came for follow-up care. And by 1 year, less than a third were in care. And by 2 years, only a quarter were in care and virologically suppressed. So we're not doing very well with our postpartum care for our pregnant women. And that's important for one, because pregnant women get pregnant again. And for two, they're maintaining their health. They really need to be maintained in care. So it sort of leads to thinking about different approaches, maybe combining the pediatric care with their postnatal care, et cetera, so that we can get both done in one. Now, what about prevention of HIV? There's some interesting data on PrEP, which stands for pre-exposure prophylaxis. And what this really is that we give an HIV medicine to an at-risk HIV-negative individual to prevent them from getting HIV infection. And this is generally given as a combination pill, tenofovir and emtricitabine, also known as Truvada, 1 pill a day. You might have seen ads about this. They're trying to ramp up the use of PrEP. Tons of studies on PrEP. Don't worry, I'm not going to go through these studies, but just to say that, many thousand people this has been studied in, women, men, heterosexual, same-sex couples, etc. The bottom line is that it works, but the efficacy you can see is quite broad, between 39 to 80%. And for women in particular, the efficacy seemed to be less. There was a lot of conflicting results. And the question is why? Was it because the drugs just didn't get into the vaginal fluids as well, and therefore there was less protection? Or is it because of adherence? And it turns out that 90% of it was adherence. There may be a little bit of a biological clause, because if the medicines don't get into the vaginal fluids quite as well as they get into the rectal fluids and into the semen. So therefore, the women have to adhere better. They have to adhere more than the men to get achieve the same level. So as I would say, women have to work harder to get to the same level. There's actually 2 very large studies that were done in Africa that found that PrEP really was ineffective in preventing HIV infection in women. And this flew in the face of all the studies in men where it was highly effective. And they went back and did some further analysis, and they found that overall adherence was quite low to the PrEP, at less than 30%. So there was some difference in vaginal concentrations, but this had more to do with them actually taking the medicine than it had to do with the medicine getting into the vaginal fluids. Before I show this, one of the things they did, they went back and did some detailed discussions with these women. And it was quite interesting because these women, part of the protocols, they were supposed to bring back their unused pills. And they would come back with their bottles empty. But then they would do drug levels, and they found that they had no medicine in their system. So these women were actually we're getting dark. These women actually were going to the extent of discarding their unused pills, but reporting that they were taking it, but they wanted to look like, trying to look like they were taking it, even though they weren't. So they went back and talked to them, and what they found was that there was a lot of issues around stigma and fear that they, if they were caught with these pills, that they would get beat up by a boyfriend or someone would think they had HIV. So there was a lot of untouched upon issues that had to be addressed when thinking about how to give PrEP or preventive medicine to HIV negative women who are at risk. And that's where this came into play. This was another study at a different form of PrEP in which women received this dipyravine ring or a placebo ring. And this is a ring that's infused in it is this medicine dipyravine, which is an HIV medication, and they insert it vaginally. It can sit there in the vagina for 4 weeks, and the drug is slowly eluted into the tissues, and then you just replace it every 4 weeks. So in this study, this was also done in Africa. Women were randomized to a placebo ring or a ring that had the medication in it, and you can see there was very good follow-up of these women. They came to all their follow-up appointments. They returned their rings, and they actually would then take the returned rings and measure the level of drug left in the ring, because that was some measure of whether they were actually using it or whether they just took the ring out and put it aside. So what did this show? Sorry about this busy slide, but the bottom line is here we have the active ring and the placebo, and this is the rates of HIV infection. So it was effective. The ring did lower the risk of acquiring HIV, but not very effective. Overall, only about 27% effective, compared to our PrEP studies with Truvada, where they were closer to 75% effective. So they then went back and did some analysis looking at adherence. As I mentioned, they measured the levels of drugs in the remaining ring. And what they found was that there was lower adherence, particularly in the young women. The women were taking these rings out, putting them away, but returning them at the 4 weeks, getting a new one placed in, going home, taking them out, and returning them. And so that actually in the women less than 21 years of age, this was completely ineffective because they weren't using it. But in the women who did use it, the efficacy was much higher, almost 50% in decreasing HIV transmission. So this is an interesting new approach that maybe takes some of the worries around stigma and will this show out of it, but obviously there's still some issues around these young women and why were they taking this ring out and what's going on there. So that's something that needs to be addressed. Okay, so now I'm going to get to the last and bulk of what I want to talk about, which is Zika virus. And I'm actually going to present a case. I don't have the final answer on this case yet, but this was a case that came to us in Columbia, South Carolina, of a 30-year-old woman who came in for prenatal care from Fort Gordon, Georgia. She was 11 and a half weeks gestation at the time. She had seen her OB in January and was sent for labs and referred for an ultrasound. Her past medical history, as you can see listed here, she was a former vet, had been in Afghanistan, had a total brain injury, had a history of seizures and fibroids and depression, anxiety. So a lot of things going on. Despite that past medical history, she was not on any anticonvulsants or antidepressants. Her only medication was prenatal vitamins. And social history, as you can see here, she was retired from the Army. Last tour in Afghanistan in 2014. She had 2 children who were healthy at home. She did not smoke, drink, or use illicit drugs. And she'd only recently moved to Columbia, South Carolina. So anyway, she did not show up for several months for her perinatal appointments and missed her ultrasound. She was actually out of care for about 10 weeks. So when she finally showed up again in mid-March at 27 weeks gestation, an ultrasound was done, and it found that the head circumference of the fetus was less than 1 percentile, which was greater than 2 standard deviations below the mean. So the story gets more interesting. It turns out she had recently traveled to Dominican Republic for vacation, as you can see, in February. Although she denied any recent viral symptoms, and she also had no sexual relationships outside of her current partner. So anyway, we had some labs, routine labs were done, including a Zika IgM, which was pending at the time that we saw her. I will tell you that it later came back negative, but we still have some reason to believe that this may be a true case of Zika. And when I talk about some of the testing, you'll see why we're still not 100% ruling this out. And this just shows the head circumference growth on her baby. So you can see it was less than 1 percentile, quite low there. So this just was a good segue into talking about Zika virus. Actually, when I was asked to do this talk back in January or something, I was like, what am I going to talk about? And then Zika exploded. I now know what I'm going to talk about. So in February 2016, the WHO declared that Zika virus was a public health emergency of international concern. Some background on this virus: it's a single-stranded positive sense RNA virus of the flavivirus family. So it's the same virus family that includes dengue, West Nile, and yellow fever. And as you know, West Nile is endemic now in the United States. Dengue has spread rapidly and is in the southern parts of Florida and southern Texas, but has not spread throughout the U.S. And yellow fever is fairly limited. It's an arbovirus, which means it's transmitted by mosquitoes, and primarily the Aedes species of mosquitoes. It's actually not a new virus. It was first found in Uganda in 1947. Since it's been identified in 64 countries and more pretty much every day now. This is a brief history of the world epidemiology of Zika. So as I mentioned, it was first isolated in Uganda in the 40s, and then from the 50s to the 70s, it was mostly just seen in Africa with a seroprevalence, at least in Uganda, of 6%. A few cases were reported very few cases were reported prior to 2007, and it's possible that mostly it was misdiagnosed as dengue or another febrile viral illness, because really by itself it's a fairly benign illness. It's only some of the secondary complications we're seeing in pregnant women that's brought it to such concern. So in 2007, there was an outbreak of Zika virus in Micronesia, and shortly after that, another outbreak in the French Polynesia, and that's when they first noted maybe an association with Guillain-Barré syndrome. There was an increased uptick of Guillain-Barré in the French Polynesia after the outbreak there. After that, it spread to many other Pacific islands, and by March 2015, the first Zika outbreak was noted in South America. About 7 months or so, 6 to 7 months after that, they began to notice an increase in the number of cases of microcephaly being reported. And that's where it started sort of really getting a lot of attention. By March, it had spread to 35 countries in the Americas, and it keeps spreading. This is just pictorial showing the world spread. By the different colors represent different years and just sort of where it's gone across the world. And this is actually online through New England Journal of Medicine, so you can look it up because they're constantly updating it. More and more countries are turning brown as illness spreads to these countries. So why did it spread so largely? Probably has a lot to do with international travel and the growing population and the emergence or the overlap of the growing population and the mosquitoes that carry the virus. And actually, its spread really echoes the spread of other viruses, and similar viruses like chikungunya. Chikungunya was a virus that was pretty much isolated to Southeast Asia, and about 3 years ago exploded in the Caribbean, and now is pretty much endemic there, as well as has been seen in southern Florida and southern parts of Texas. It's, as I mentioned, a mosquito-borne virus, and it's spread by the Aedes species of virus. And the thing about these mosquitoes is they bite at the daytime, and they're very urban. They like to live in urban areas. You know, usually you can avoid mosquitoes if you just don't go out at dusk. But these bite all day. You know, what are you going to do? You're going to stay in forever? And it's been the Zika virus has been confirmed in many different species of the Aedes type, the most common being the aegypti and the albopictus. That's just a picture of one of our mosquitoes. I never could identify a mosquito because whenever I see them, they're splat gone before I could even begin to look at them, so I never try. So where are these mosquitoes? Well, here's the range of the Aedes aegypti mosquito. So in blue here, you can see where its range is. So it's really quite far up to even southern parts of Connecticut. And as you can see in the southeast, we're an abundance of these mosquitoes. Here's the range of the Aedes albopictus. And that's even further north, up almost into Maine. Actually, lower Maine it is. And again, we're quite widespread of these mosquitoes here. This is actually an interesting analysis that was done by the CDC, where they tried to determine cities at risk in the United States based on several factors they took into account: whether they had the right mosquitoes, the right climate, and how big the population was, and how much travel from endemic countries to that city were. So, you know, if you have, because the belief is that someone will carry it in, have the infection asymptomatically, get bit by a mosquito locally, and then it will get into that population. So the bigger the circle and the darker red, the higher at risk. And so you can see of the 10 highest at-risk cities, we include here Charleston and Savannah, as well as several cities in southern Florida. And I've noticed that Columbia, South Carolina, where I'm from, is in a middle risk city. But I think they forgot that we had a flood and that the mosquito population just exploded in the past year. So I'm wondering if our risk is even higher. The good news is, despite this prediction of these maps that was done several months ago, we're now in the thick of the summer season, and we have not seen any locally transmitted Zika virus. So this prediction may not pan out. This is actually the cases of documented Zika virus in the United States through June 22nd. In the darker green have more cases. Overall, there were 819 cases documented. All except 11 of these were from people who acquired it somewhere else and then returned and were diagnosed here. The 11 cases that were acquired locally were sexually transmitted cases. So there's been no locally acquired mosquito-borne infections of Zika virus in the continental U.S. In Puerto Rico, there isn't locally acquired infections in some of the other U.S. territories in the Caribbean. So how is it transmitted other than mosquito? Well, we now have very good evidence that it's vertically transmitted from mother to child or mother to fetus. With Zika virus RNA has been found in amniotic fluid, placentas, fetal membranes, and the umbilical cord, with the highest Zika viral loads in the infected fetal brains. And Zika virus RNA has been isolated in paired blood samples from newborns and mothers. In addition, there's serological evidence of past infection in newborns with congenital microcephaly. A lot of data. I think it has been determined that yes, Zika virus is transmitted from mother to child and is the likely cause of microcephaly in some cases. It can also be spread by blood, as in particularly what the particular concern is the blood supply. During the French Polynesia outbreak, Zika was detected in about 3% of asymptomatic blood donors, although there were no reported cases of blood transmission. In Brazil, there have been some reported cases of Zika virus that was transmitted from blood donation. And actually, the FDA now recommends that local blood collection stop in areas of the U.S. affected by vector-borne Zika transmission. And that's particularly impacts Puerto Rico, where it's now endemic. So they're not allowing local blood transfusion or blood donation. So all their blood supply has to now be imported from other parts of the continental U.S. The FDA also recommends that people who travel from active Zika areas don't donate blood. So again, another thing that's diminishing the U.S. blood supply. Zika virus has been confirmed to be transmitted sexually. There's been several cases of male to female. There was one case of male to male, and just last week there was a case of female to male Zika virus transmission that was reported. The Zika virus RNA has been detected in the semen, and it's been detected in the semen up to 62 days after symptomatic illness. And there was at least one case report of late sexual transmission 44 days after Zika virus illness. So the semen may be a sanctuary site where the virus can last longer than it does perhaps like in the bloodstream and can persist even after symptoms have gone. And the placenta is also another sanctuary site where it can last and persist much longer. And this sounds unusual, but we've actually learned from Ebola that this is not that unusual. Ebola is the same thing, that people who can get Ebola, those who survive, the virus can persist in these sanctuary sites for months later and be a source of ongoing transmission. Zika virus has been isolated from saliva, but there's been no documented transmission from saliva. Similarly, Zika virus has been isolated in breast milk, but there's been no documented transmission from breastfeeding. But something to think about as you advise women who might have had or been exposed to Zika virus. As far as illness, in the otherwise healthy individual, it's a fairly mild flu-like illness. One of the prominent symptoms is this macular rash. They'll have low-grade fevers, arthralgias, myalgias, headaches, and conjunctivitis. And men will sometimes report hematospermia. But it's fairly mild and very nonspecific, and it usually lasts less than a week. So incubation period from time of exposure to onset of illness is between 3 to 14 days. And then if you develop clinical illness, many people are completely asymptomatic. Illness is short-lived, up to a week at most, in the otherwise healthy individual. So for most people, it's a nothing to get it. As a matter of fact, you might want to get it so that you have protective immunity so you don't have to worry about getting it in the future. And one of the reasons why perhaps it's not had such a big impact in Africa is because it's been there a long time, so a lot of the population has been exposed and has protective immunity. And it's only when Zika virus came into these new regions of the world where there was an unexposed and therefore unprotected population did we see these explosion of secondary complications. Illness is quite similar to other arboviruses in the region like dengue and chikungunya, so clinically it's really hard to distinguish. There's all these scoring things, but honestly there's such overlap you really can't distinguish them clinically. Now, as far as the feared complications, just want to touch on Guillain-Barré syndrome a little bit. So there has been a temporal relationship between Zika virus outbreaks in the French Polynesia and an increased incidence in Guillain-Barré. Now, French Polynesia is not a very big population, but they, in this population, when Zika virus came, they had 38 cases of Guillain-Barré temporally associated with Zika virus, which led to an odds ratio greater than 34 for developing Guillain-Barré after a previous Zika infection. So it's a huge odds ratio, not a lot of cases because it's a small population. There's similarly been increased numbers, although it's not been quantitated, of Guillain-Barré in Brazil that have been temporarily related to the Zika virus outbreak. But this risk is still relatively low. And to be honest, many viral illnesses are associated with Guillain-Barré. So if you introduce other viruses into a community, you may see an increased incidence of Guillain-Barré. So it's not, although it's not nil, it's not a huge risk. So the other feared complication are the congenital complications. And this is just a picture of a father with his newborn baby who you can see clearly has microcephaly. This was from Brazil. That came out after the increased reports of microcephaly in Brazil. So the links to microcephaly, they're numerous now, and I'm just going to go through a few of the links. This was so the cases of microcephaly increased 20-fold in newborns in northeast Brazil between 2014 and 2015 after Zika virus came to that area. And actually, they were following over 7,000 cases of microcephaly or other central nervous system malformations, of which about a third of them, or 3,400, they've done their complete investigation. Of those 3,400, 1,168 had confirmed microcephaly or other CNS malformations. So a third of those were definite microcephaly. Which led to a national average annual rate of 163 cases a year, which was well over previous rates. There was also increased rates of deaths during pregnancy or shortly after birth, and some of these may have been related to Zika virus. Again, hard to confirm. Most of these are still under investigation. Probably the most direct link was a case that was reported in the New England Journal of a healthy pregnant woman who got infected with Zika virus at the end of her first trimester. She had ultrasounds at 14 and 20 weeks, which revealed normal fetal growth and anatomy, but then an ultrasound at 32 weeks showed marked intrauterine growth restriction with placental calcifications, microcephaly, and intracerebral calcifications, and ventriculomegaly. She actually terminated the pregnancy and a fetal autopsy was done. On external exam, the fetus had microcephaly. In a macroscopic exam, there was enlarged sylvian fissures, a small cerebellum and brainstem, a loss of the gyri and hydrocephaly. And on a microscopic exam, there was calcifications in the cortex, subcortical white matter, as well as in the placenta. And by indirect immunofluorescence, there was evidence of intracytoplasmic virus and reactions with destroyed neurons. And they actually did isolate Zika virus from the fetal brain, and the levels in the brain were much higher than were found in the serum. So there seems to be a tropism for the neuronal tissue. This is just some pictures from that case, showing, I can't read that ultrasound. Maybe many of you are better at reading it than I am. But here's the autopsy, showed the big fissures and just some calcifications. And here are the the electron micrographs that show the virus isolated within the neuronal tissue. So it's a pretty convincing case. There was another study of 88 pregnant women during the Zika outbreak who presented during pregnancy with a rash. And of those 88 women, 72 of them had definite Zika virus based on finding the RNA in either their serum or urine or both. So they went on and followed these women. Actually, 42 of those 72 women went on to have serial ultrasounds. The other women who didn't is because they didn't want to know, or they couldn't travel for the ultrasounds. And 2 of them actually miscarried early on. They also followed the 12 women who did not have Zika virus. And what they found is that a third of those women who had documented Zika virus had evidence of intrauterine growth some sort of intrauterine growth retardation, cerebral calcification, microcephaly, or a combination of all these. The other things they found is that they found abnormal amniotic fluid would decrease cerebral artery flow and decrease umbilical artery flow. And there was actually 2 fetal deaths early on that were felt related to the Zika virus. And the control group had no abnormalities, which sort of put some doubt. Some people were saying at the time, it's not the Zika virus, it's some other environmental exposure. It's all the DEET you're giving us to prevent us from getting Zika virus. So this sort of study put some doubt to that, but also is convincing evidence of the association of Zika virus with microcephaly. Now, the full range of congenital illness is really not known, and we're learning more and more every day. But one thing that's come out more recently is probably the greatest risk of microcephaly is with maternal infection during the first trimester, and that's not unexpected. We see that with other maternal viral infections, that the first trimester is a critical time. And at least one study recently suggested that infection in the 3rd trimester is really not associated with any risk. Not that I would advise a woman as such. I would still want them to be careful and avoid Zika. As far as diagnosis, this is not an easy thing to diagnose because clinically it's nonspecific and it overlaps with other viruses in the area. There are 2 diagnostic tests that sort of received emergency use authorization. One is a PCR-based test, and the other is this MAC ELISA or IgM test. Now, they have to be done at qualified labs, and if you're suspecting Zika virus, it really should be reported to your public health department. So in South Carolina, we send it to DHEC, and they'll go on and do additional testing and send it on to CDC for the final testing. The PCR assay looks for viral RNA, and it can be found in either the serum for up to 1 week after symptom onset or in the urine for up to 14 days after symptom onset. It can also be done on CSF, amniotic fluid, and semen, but that's really for research purposes only. So for clinical purposes, serum or urine, and just keep in mind that it will be positive in the urine longer than it will be in the serum. Of course, it's still short-lived, so you could miss that window, and it's not a perfect test. So the IgM test is a test you can do to sort of help pick up people who might present a little later. So if you have a negative PCR or symptom duration was greater than a week or earlier, you can go on and do this IgM test. The problem with this IgM test is it cross-reacts with other flaviviruses in the area. So if you have a positive IgM test, you really need to send it to the CDC where they do this fancy plaque reduction neutralization test to look to see if the reaction to dengue is less than the reaction to Zika. And that's not something you can commercially get. It has to be done by CDC. So it's expensive and time-consuming, and you often don't have the diagnosis until after the fact. So alternatively, there is this, what I call the poor man's version, where you do a Zika IgM and a dengue IgM, and if you see a difference where a higher Zika IgM versus dengue, you can make a presumptive diagnosis. But to make a definitive one, you really need to send it on to CDC. As far as treatment, there's no specific treatment for Zika infection. It's just really symptomatic, Tylenol and antihistamines. So prevention is the major thing that we need to focus on. Okay, I'll be 10 more minutes, 5 more minutes at most. So there's no vaccine, so protection is really based on avoiding mosquito bites, all the usual things we say, long sleeves, light-colored clothing, and repellent, including DEET, which is recommended and considered safe during pregnancy. And also environmentally decreasing the number of mosquitoes, so get rid of your standing water. I used to have in my backyard this pot that sit there and would collect water, and that's now sitting upside down so it doesn't collect water. They have actually been doing some studies looking at genetically modified mosquitoes to decrease the mosquito burdens. And then there's a lot of travel warnings for pregnant women that they shouldn't go to areas where Zika is endemic, or they should delay conception if they've been in an area where Zika is endemic, keeping in mind that more than half of pregnancies in the infected areas are unplanned. The CDC has actually come out with some guidelines for pregnant women or male partners of women who may be pregnant or planning on being pregnant. And I'll run through them quickly. What they recommend is that women with Zika disease, so they have symptoms, should wait at least 8 weeks after symptom onset to attempt conception. Men with Zika disease should wait at least 6 months after symptom onset to attempt conception. And that's because, as I mentioned earlier, Zika has been isolated in the semen for up to 62 days. So they sort of triple that and say wait 6 months. For women and men with possible Zika exposure but without clinical illness, they should wait at least 8 weeks after exposure to attempt conception. And exposure is having traveled or resided in an area where Zika is active, or having sex with a man who traveled or resided in an active Zika area. And now that we have a case of female to male transmission, that may get modified, having sex with anyone who was in an area where Zika was active. All pregnant women with possible Zika exposure should be offered testing. And that includes if they were exposed up to 8 weeks prior to conception. If they're asymptomatic, they should get an IgM test. And if they're symptomatic, they should get an RNA test if their symptoms have been there for within the past 2 weeks. And that should be followed with an IgM test. The guidelines, and there's a nice algorithm in the CDC, so I'll refer you to that to really look at if you have a case and you're concerned. But if the Zika test is positive or inconclusive, then you should consider serial ultrasounds. But if it's negative and the concern is real because of the real exposure, you might also consider going on to do ultrasounds. And if you see abnormalities, getting repeat testing because the testing is not perfect. And this is sort of the algorithm that the CDC came up with, which I won't go through, but you can pull that up if you go to the cdc.gov website and you go Zika virus. You'll find more than you want, including detailed, up-to-date guidelines that are changed based on minute-to-minute data. Now, for men who have traveled to areas with active Zika or a possible Zika infection, if they have a pregnant partner, it's advised that they avoid unprotected sex throughout the duration of the pregnancy. And that includes vaginal or anal intercourse and fellatio. For men and their non-pregnant partners, they should avoid unprotected sex for at least 6 months after Zika illness, or 8 weeks after exposure if they're asymptomatic. And then just a little bit on fertility treatment. It's possible that transmission could occur through a donated gamete or embryo. So, and that the cryopreservation methods that are used will not necessarily destroy Zika virus. So, for anonymous donations, the FDA deems ineligible donations from someone with diagnosis of Zika infection within 6 months, or who resided or traveled to an area with active Zika transmission within 6 months, or had sex with a male partner, and again, that may change to any partner with the new data, who's been diagnosed or had symptoms consistent with or traveled or resided to a Zika infection within area within 6 months. If it's a directed donor, it's acceptable as long as the tissue is properly labeled and everything is known and agreed upon by participating parties. And just end with a little bit of reasons or cause for concern. Some of this may not bear out, but as I said, the growing consensus based on all the data we have now is that Zika virus is the cause of microcephaly and other CNS malformations, as well as associated with Guillain-Barré syndrome. The outbreak in the Americas and South Pacific is exploding. We're not sure if it's over yet, but it may start to calm down as more and more of the population's been exposed and is immune. The spread of Zika virus has been fueled by the spread in the Aedes mosquitoes and this increased urban population. These are urban mosquitoes. We have more people living in the urban areas, more international travel, so there's just more and more exposure. And these mosquitoes are tricky. They've adapted to cooler climates. The ones that the Aedes albopictus that's seen in Florida may actually be more susceptible to the Zika virus than those found in Rio de Janeiro. And of course, there's a concern next month with the Olympics coming up. Is that going to lead to a spread of Zika as people return from the Olympics? I think you've heard in the news some participants have declined to participate as a result of the scare of Zika virus. And I think that the attendance at the Brazil Olympics is going to be down. And then in the United States, obviously, the concern is the same concern that happened in Brazil, is that you had a population of women who were immunologically naive to this virus and therefore at greatest risk for vertical transmission with its grave outcomes.